Good day, everyone, and welcome to today's webinar, CMS Care Coordination, Empowering the Present and Shaping the Future. Marcella Wright is our presenter, and she's up in Wyoming, and she just lost internet. So we're going to do the best we can. And I'm going to run the slides, so I'm going to swap back over to that now. Let's see from the beginning. Okay. Marcella Wright is the Director of Care Coordination and Lean Consulting with HealthTech. Her nursing career spans over 30 years and includes consulting, acute care, home health, renal health, and academia. Marcella has a lifelong passion to provide whole person care and coordination of chronic illness. She has been a certified mental health nurse and a certified nephrology nurse, has been a member of the American Nurses Association, American Nephrology Nurses Association, and the American Academy of Ambulatory Care Nurses. Marcella has a passion for community and population involvement and has dedicated hours to youth sports, agriculture, leadership, and church youth groups. So at this time, all of your lines have been placed on mute to prevent any background noise. We'll have a question and answer period at the end, and you can type your question using the question prompt, and we may be swapping screens back and forth like this unless she gets internet back up. When typing your questions, please identify the name of your organization at the beginning of your entry. This webinar is being recorded and will be available in the CIHQ YouTube library within a couple of days. It's now my pleasure to turn the conference over to Marcella. You have the floor.
All right. Can you hear me okay?
Yes, ma'am. Very well. Thank you.
Okay. Thank you. And I sincerely apologize to everyone attending. I do live in rural Wyoming, but I haven't lost internet at work in almost a year. So this just happened, and here we are. So I wanted to, if you could share the next slide, please. What we want to talk about specifically here is what care coordination is and the growth and development of it. Now, you'll look at this slide, and for any of you that have done grad school, this slide right here is a no-no, and I know that. It's got way too much information on it. But this is just an idea to show you that any sort of care coordination, wellness prevention was started by CMS in 2011, and that was initially with the annual wellness visits. But as you can see, each year it has grown and something new has been added to the process. So we go through 2026, and the most recent changes that have been made is rural health clinics and federally qualified health centers can now bill just the same as fee-for-service clinics. That's been one of the biggest changes. And then they've expanded the assessments that you can do. Next slide, please.
I believe I'm a slide behind. I'm going to go one more ahead.
Okay,
everyone,
thank you.
The handouts are in, or should be accessible to you as well. Thank you, Marcella.
Thank you.
There you go.
Okay, so now we're going to talk about the model. So what is care delivery and why did CMS make this change? Well, what we were finding is that a lot of times with one of the things that we were finding, is that we were having difficulties with patients having fragmented care, and there wasn't that cohesive or that flow that the patients needed, and it was just episodic. You go in for a sore throat, you go in for a headache or whatever, and sometimes they're not connected. And a lot of times, especially if you get referred out to a specialist, then your care was not tracked and you weren't able to keep it going. So what they've done is they've now really stressed that there's a care coordinator and that we do a team-based care. Next slide, please. So one of the goals that we have with care coordination is wellness and prevention, okay? So when people initially went on Medicare, and Medicare was the way that people talked about how it was going to be done, they thought you were going to be on Medicare for 6, maybe 10 years. Well, the average lifespan now, people are on Medicare for more than 15 years. Females, for sure, are more than 15 years. And so we've got to look at it more as a preventive and a wellness. So while we're doing that, what does care coordination do? Well, it leads to better health for the population, better outcome for the individual, lower costs through improvement, and then something that we hadn't looked at and something that hadn't been considered very well was the work-life balance for all of those in the clinic. Many of you on this call may be in rural health. Think about how difficult it is for you to get a primary care provider. Think about how difficult it is for you to get AAP to come to your area and then to stay, because so often they're burnt out. Think about some of your providers that never have a day off, truly. You know, they cover the skilled nursing facility, they cover the ED, they cover inpatient, they have their outpatients they carry. Think about what you can do if you help them with that load. Next slide, please. So one of the things that we talk about here is the deliberate key elements that we have within care coordination. You need to have quality primary care. You need to have organized care and activities. All healthcare needs to participate in it. Pre-visit planning is so important. If there are things, I'm going to throw out an example. My husband had an appointment yesterday with his primary care provider. He had ordered the labs, the provider had ordered the labs to be done before the appointment. Well, my husband only got them done about 3 hours before the appointment. So she didn't have access to those, but think about what a difference that makes in an appointment if you already have what you are looking for. So I know a lot of what we're going to talk about in this slide today, or this slide deck today, we are going to talk about the outpatient setting. I want you to consider the outpatient setting is not a completely different facility from you. They are just another unit that you work with. You don't discharge a patient, you do transitional care and you transfer them to the other unit, which is outpatient and their home. So that's what's really important there. Next slide, please. Now, the Institute of Medicine has really emphasized the key strategies that give us the greatest potential for improvement, and that's effectiveness, safety, and efficiency of the American healthcare system. So, how many of you right now would boldly raise your hand in a group and say that the American healthcare system is effective, safe, and efficient? Well, as a nurse, I like to say that we're pretty darn safe. Yes, we're human, we make mistakes, but are we efficient and are we effective? I think those are areas that we need to have better design, and we need to be able to meet the needs of the patients, the providers, and the payers. Next slide, please. So what are some of the current obstacles we face in doing care coordination, and why are we not doing care coordination? So some of the things, we have disjointed care. So we have a provider who needs to send somebody out to cardiology. I'm going to share a quick story I got back from somebody that was taking one of my courses just this week. She said she had a lady that was referred to the cardiologist, came back from the cardiologist and said, yeah, I was told I was supposed to get some sort of test and I didn't know what it was and I didn't even remember it, so I haven't done it. Well, that had been several weeks and it was a TEE. This patient needed it and the order from the cardiologist said to do it as soon as possible. So this patient didn't feel well, but she didn't know any different. She didn't order it. She didn't know, but the care coordinator caught that, followed up on it, and within weeks of having the TEE and some adjustments to her medications, she felt so much better. So I want to say that this whole slide demonstrates that story right there. She was able to, through her care coordinator, get the test that had been ordered. Next slide, please. So some terms to think about when we talk about care coordination and the development of it. Collaboration. Think about everyone you need to collaborate. Team-based care. Please look at care coordination as an RN, you can function at the highest level of your education. A social worker, an MA, you can all function at the highest level of your education, but please do it as a team. And keep in mind, there are things that people on the team are doing that sometimes aren't being tracked. You're not giving yourself credit for, but you're doing them. You're going to manage the disease process better for the patient. The patient's going to have continuity of care, and we're going to be able to follow chronic care models. So if a patient is pre-diabetic, it gives us the opportunity to prevent that advancement or the worsening to diabetic if we intervene early. So next slide, please. So team-based care. Who's on the team? I already mentioned a few of them, and this is probably pretty straightforward for you, and you can think about this. But the team-based approach, you have your multidisciplinary team, which obviously always is going to have a billing provider. The billing provider can be an advanced care provider or a physician, DO, MD, or it can also be a nurse midwife. Probably not something we deal with a lot when we're dealing with the Medicare population, but I want you to know that. Now, who's on the team and who's going to help? You can have pharmacists, social workers, dietitians, community health workers. There's so many people that can be on. And then mental health professionals. Then you have the care coordinator. Now, at the hub of all of this care you're giving is the patient. They are the number one. But I also want you to recognize that as the care coordinator, you're the one with the passion. You're the one that truly is the trusted caregiver for that patient. And that patient, I had one lady that commented to me that she's fairly new to care coordination, and she said she felt so happy when one of the patients called the clinic and asked for her specifically. It's like the patients are starting to get it. She said, we're in our infancy, but that felt good. I want you to recognize that. Next slide, please. So the team-based approach, again, it's holistic care. We're not doing the fragmented. We're not doing episodic care. It's all about the holistic patient. We want to enhance their satisfaction. It needs to be comprehensive care. If this is a patient who has problems with urology and they also have mental health issues, we're covering both. We're going to take care of those in chronic care management. They can be covered separately, but we'll get to that in just a minute. But it reduces burnout of the providers. And when I say providers, I'm talking about those of you in the clinic besides the providers as well. And then it's a great use of resources. An example, how many times have you had a patient who goes and sees their primary doc and something's ordered, then they're referred over to a specialist and the specialist does the same test? Say, let's just throw out a liver panel. The patient, that's double doing, and it's a waste of resources and it's a waste of time for the patient as well. Next slide. So the delivery of care coordination. So the key responsibility when you're doing care coordination does fall in primary health care, typically, okay? You may have an organization that's doing principal care management and you're a specialist, and you may be the only one that's providing coordination for that patient. That's an exception, okay? We're talking about primary care. And we recognize as nurses that the needs of the patients are becoming more and more complex. So as the RN coordinator, if you have a patient that's got 5 chronic diseases, you know that patient, and you know what's going on with them. Say they call one day and say, hey, my blood sugar is 160 today. You may know that patient well enough that you're like, wow, that's pretty great for them. But if they call and tells that to somebody who doesn't know them very well, they may kind of panic and go, okay, what symptoms are you having? Have you been taking your meds? But it's all about that continuity, and you know the patient and all their complexities, and we know they can be many. So you're going to create a patient-driven care plan. Don't panic when you hear care plan. This isn't an ANDA care plan. This is a patient-driven care plan written in patient words. If you ask the patient what their goal is with their diabetes, likely most of them will not say, I want my A1C to be 7.1 or less. They may say, I want my A1C to improve, or I want my sugars to get better. That's their goal. That's what they want to do. Then you ask them, what are you willing to work on? Well, I don't know. Maybe I'll cut out that donut I have with coffee every morning, or whatever that is. That's their goal. So then you're going to advocate for them to make sure that they continue to get dignified, holistic care. That's what we do as nurses, and especially as a care coordinator. Next slide, please. So patient-specific plan of care. I mentioned this already, but I'll just say again, it's patient-driven. Then there's another thing we like to talk about, and we consider it's the 4M model. And what that is what matters to the patient, what is, and what matters to them is one of the W's. And the other things, excuse me, that's an M, not a W. The other things we look at with the M is mobility, mentation, and medications. Think about how important all of those are with our patients that we take care of. Then we're going to facilitate and we're going to collaborate. We're going to use validized tools that ensure we're staying in the same lane that we need to. We're going to do what needs to be done for the patient to best meet their needs. Next slide, please. So care coordination. So one of the important things, okay, great, you're telling me about all of this. So we have 1,000 Medicare patients in our clinic. Where do I even start? Well, one place that we suggest to people is look at those patients that come for regular office visits. Do you have a high needs patient that maybe feels like they need to see the provider once a month or every couple weeks? Consider them, okay? Look at them and say, okay, look at the calendar and say, hey, Dr. Jones, I see that Ed Smith's coming in to see you again in 2 days. I've looked through his chart. I see that he has chronic conditions. I think that he could really benefit, and it would utilize the care coordination program appropriately if we admit him. Then that's how you could talk about recruiting him. Another place to recruit would be in the annual wellness visits. Now, every patient, I'll talk about these a little bit later, but every patient qualifies for an annual, every Medicare patient, Part B, qualifies for an annual wellness visit once a year. And those annual wellness visits are paid 100% by Medicare. They're also qualified for a certain amount of tests. And this is more information, screenings and tests. And this is more information that I'm going to get into at this point with you because we're going to cover so much more. But then another way to really recruit patients, say you're just starting your program and you've done the first 2 and you're like, okay, now where can I go? Go into the EHR, start reviewing. A lot of times in these small communities, we have one organization we work with, she knows so many of the patients already. And she's like, oh my goodness, this patient would benefit from it. Or she's like, I don't know about this one, but I'm going to call and talk to him because I know him. Think about things you can do there if you review their chart. So now let's back up a little bit, and we're going to talk about annual wellness visits because I just want to be clear. Care coordination and annual wellness visits do work very well together. They're not the exact same thing because care coordination deals more, chronic care coordination is usually, it deals more with the chronic diseases, and annual wellness is prevention and it's for prevention and wellness for the patients. So what are you going to do when you work with the patient? So I want you to recognize this program has been around for 15 years. And I want you to stop and think at your clinic, are you currently completing the annual wellness visits? And if you are you completing those by a registered nurse, or are they being completed completely by the provider? And I'm going to ask the question, if the provider is doing them as we go along, I want you to recognize if they're being done appropriately. I can tell you that 90% of the clinics we go into where the provider says they are doing them, they are not being led or being completed the appropriate way. So that is something that we need to be aware of. So what you do in the annual wellness visit is you set their goals. You help them look at health promotion, disease prevention, early detection. You're going to coordinate screenings, and then there's going to be the coordination of preventive services as well. Next slide, please. So the beneficiary needs to know they qualify. Once they enroll in Medicare Part B, they qualify for an annual wellness visit. Now, that's something that's done annually, but I want to throw this out to you. It is not a physical. Once a patient is on Medicare, they will not get a physical paid for by Medicare again. That confuses patients. They're like, well, I went in and I had this exam and they didn't even use the stethoscope or touch me except to get my blood pressure. Well, when we're doing prevention and wellness, that is how we do it. If they need something that needs to be checked, we can schedule another appointment for them to come in. But if you do anything that's medically necessary on that visit, it is no longer an annual wellness visit, and the patient will have a copay and they will need to pay that deductible. So that does not apply with the annual wellness visit. Okay, there are 3, next slide, please. There are 3 different codes and different ways to look at the annual wellness visit. So under Medicare Part B, it is 100% covered. Remember that. You have the initial preventative physical exam. I wish they wouldn't have put exam on that because then people think they're going to get a physical exam, which they are not. Then that is within the first 12 months of getting Medicare Part B. So if it's after that 12 months, they've never had one, then they're going to get their first annual wellness visit. And it's basically the same thing. It just has a fewer steps that can be in the IPPE, which is the initial one. Then after the patient has their very first one, Every year after that, it's a subsequent. Now, how often can it be done? It's annual. So if a patient comes in tomorrow, which is the 15th of July, and has their annual wellness visit done, they are qualified to come back next July. Anytime in July. It can be July 1st, it can be July 30th. But they're kind of stuck in that July month going forward. It cannot be shorter, and it can be longer, obviously, and you're going to have several of those that do that, but it cannot be shorter than that month that qualifies them for the 365 days. If that's confusing, I'm sorry, but that's the best way I can explain it. Okay, so what are the required elements and the ABCs of the annual wellness visit? It's individualized, it's preventive, it's personalized, and you develop a plan of care. When the patient walks out of that office after having an annual wellness visit with you, you are going to give them a printed plan of care that helps them recognize what they need to accomplish through the next 12 months. And these are goals that they have set up. These aren't things that you just randomly decided for them. Next slide, please. So that personalized plan of care, how are you going to develop that? Well, first of all, you are going to do a completed assessment with a screening. Then you're going to review any of the specialist reports that they have had. Have they been to urology, oncology, hematology, cardiology, neurology? Have they been anywhere like that? Review their chart. Hopefully you have access or the records have been sent over. Review those, summarize them, make sure the provider's aware that they are there if they need to be reviewed. If everything is, patient's baseline, same as last year, let the provider know that. But you then also need to review their suppliers and their providers. So, do they have DME and do they have multiple providers? Who's their podiatrist? Do they have a chiropractor? Do they see physical therapy? All of those things, you need to make sure that you have that information and it's accessible through the electronic medical record. Next slide, please. Okay, the preventive plan of care, the 3 key elements you need to remember about this, okay? Number 1, you're going to establish a written screening schedule for them. You're going to make a note that you'll get your flu shot in September, October. You need to get your shingles booster or whatever, your pneumovax, whatever those things are. Or you need to come in for your quarterly A1C. You need to go to the eye doctor, those type of things, okay? Then you, based on the risk assessments, screenings that you have done, and based on the patient's history, you're going to identify any risk factors or conditions that may need interventions, and you're going to put those on the care plan. Did they not do very well on their stand and go test? What are you going to do about that? Well, you may need to refer them to physical therapy, or they may need to see a podiatrist. Maybe something's wrong with their feet. Then the other thing you're going to do is it is going to be a personalized health advice with referrals. However, unless they're on CCM, you want them to do self-management and care for themselves. You are not going to be calling them on October 1st, have you gotten your flu shot yet? As part of the annual wellness visit. Now, you may be doing that because that's the system you have. I mean, I worked in outpatient hemodialysis, and indeed, that's kind of how we dealt with our patients. We reminded them frequently, you're due for your hepatitis B booster, your titer was low, you're due for your pneumovax, you're due for your flu shot. And when it was COVID, we did that. So those are important things that you will be doing to help them when you write that care plan. You're not going to be calling them to remind them. Next slide, please. Okay, so these are some numbers I want you to see. So those of you that are fee for service or professional fee service, you will notice that the allowable payment for the IPPE is $174, as well as the initial annual wellness visit. But if you get an air payment at the FQHCs or the RHCs, then obviously it would be different than that. But look at your subsequent payment of what you get each year after. Now, these are obviously much higher than you're going to bill for an E&M visit on a typical patient. So when you have a doctor who has a patient, we have one doctor who's, he has said that he doesn't think nurses are qualified to do the annual wellness visit. He needs his toe stomped on for that. But I think above and beyond that, he says he can do an annual wellness visit in 8 minutes. Nope, you cannot do an annual wellness visit complete and as required within 8 minutes. As we like to say, that's fraud because you're not meeting all the requirements that we've talked about. Okay, so I'm going to jump over now. We've done annual wellness visits, and now I want to talk to you about chronic care management. This is the one that we actually deal with the most with all of the organizations we work with. So it is usually in primary care, and it's chronic care management. So it's a critical component. It allows reimbursement for all of that time that you are already spending outside of the appointment. One facility we work with is spending so much time in the beginning of the year following up with Medicare Advantage, to try to determine if a patient qualifies for all of these services. Track that time once the patient's in the program and has consented. And then it's a great way to manage your traditional Medicaid patients. Now, Medicaid Advantage is paid, and in some states, Medicare Advantage does pay for it. And in some states, Medicaid also covers part of it. You would have to check your state to see if it does. Next slide, please. So, chronic care management, how does the practice remain eligible, or how do they become eligible? First of all, you have to have a qualified EMR where you can document this stuff. You have to have electronic patient communication availability. Now, that's the patient portal or whatever you choose to use. I have seen that isn't utilized near as much as I think it should be, but I think it's a great way to do it. I'm not quite Medicare age. I love the patient portal. My chart, I go in there and send a message and it's taken care of. Then you're going to collaborate electronically with anything in the community that may be attached to it. Say your public health office is attached to it, and you can communicate with them about the need for vaccines. Now, here's one that sometimes throws people off. You have to be able to provide 24/7 coverage. Let me clarify that. If you are attached to a hospital and they have an ED or they have an inpatient unit, that is your coverage. We had one facility we worked with that they did have an ED and an inpatient unit, but the nurses loved their patients so much and felt a sense of responsibility for them that they started carrying a cell phone. They were on call all the time. Do not do that. Please do not do that. Then the next thing, you have to create a care plan and they have to have access to it. Then it's called general supervision. So if we go to the next slide, I'm going to explain to you a little bit about what general supervision is. So when we are dealing with the codes that we are specifically talking about, the care coordination, and then we're going to talk about behavioral health a little bit, the provider does not need to personally provide the service. This is under general supervision, but you're billing under them, so they have overall direction and control. And the provider is not required to be physically present during that service. So if the patient, say the doctor takes Tuesdays off and that's when you make a lot of your CCM calls, that's okay. That's okay. That's perfectly legal. Next slide, please. Now, the other one I want to talk about real quick is direct supervision. Now, if you are an RHC or an FQHC, you have to have direct supervision for the annual wellness visit. What that means is they have to be in the office, or you can easily get them if there is an emergency, and they can furnish any sort of guidance or direction that you need. And they don't have to be in the room with you doing it. Typically what happens with annual wellness visits and direct supervision, they come in for the last 10 to 15 minutes of the appointment and they answer any questions the patient may have about the annual wellness visit and the plan of care. They are not talking about, oh, your shoulder hurts, or, oh, your hip, how'd your hip surgery go? Those are things that you've already covered and it's on the plan of care. If they want to discuss those, they need to schedule another appointment to come in with the provider. Next slide, please. Chronic care management. How is a patient eligible for CCM? So I would say, we talk specifically about Medicare here, but some insurances cover it. I'm just going to throw that out. There are some. But to qualify for CCM, you have to have 2 or more chronic illnesses that are expected to last for 12 months or more. And without intervention and without help, they are at a significant risk of decline and possibly death. Now, we don't want that. The other thing that's super important you cannot forget is the patient must consent to have the service. You can't just sneak it in on them and start billing for it. So it can be a verbal consent or a written consent, and we generally recommend you have a consent form that's global that would include them in the different service lines that you may want to use. If you go back to that first slide that was so busy, those are all service lines, and there's 15 different service lines available through care coordination. The next thing would be that it's initiated by the primary care provider. Does that mean that you as an RN in the clinic who recognizes a patient may need it, you can't say, I think you might qualify for this program and then talk to the provider? Absolutely not. But the provider can see them and say, hey, they need this program, or you can see them and go to the provider and say, hey, they need this. He has to say, and maybe quick documentation that patient was seen by me 2 months ago. They have to be seen within the past 12 months by the provider. Okay. So it's not like I saw this patient 6 years ago and I think today they would be a good candidate for this. They have to have been seen in the past year by the provider, and the provider, it doesn't have to be an E&M visit to initiate it, but you do initiate it based on the provider. Then you are able to track time after the consent is signed, and it's a minimum of 20 minutes that you have to track each month. That's every single month, minimum of 20 and up to an hour if you're doing those services. Okay, next slide, please. Now, excuse me, something I want to talk about real quick is complex chronic care management. What's the difference between care management and what's the difference between, complex chronic care management? What's the difference? It's on here right now. So complex still has to meet all the same requirements as CCM. However, with complex, the patient has a medical decision that needs to be made that involves the decision being made between the care coordinator and the provider. Prime example is an adjustment to INR, or adjustment to anticoagulant, not INR, but also a potential for, say, blood sugars. That's another one that requires a lot. I think congestive heart has a ton of times that it goes back and forth with the provider. If you spend at least an hour, you can bill for complex. Moderate or high complexity, the medical decision, and it's that two-way communication. One of the things that I like to throw out with this is where the patient is needing that phone call back after they call in with a question. Then say the doctor wants their weights, and then the doctor wants their blood pressure monitored. Those are the kind of things, and you can track as much as you want. The first has to be 60 minutes, and the next ones that you can bill for, they are in 30-minute increments. I thought there was a limit of 4, so you could only bill a total of 3 hours. I looked it up just this morning on the CMS frequently asked questions. There is no limit to complex. So if you have a patient that's very complex and is requiring a lot of time, I recommend you use complex. You don't stop at just CCM and only give yourself credit for the hour of the time you're putting in. Next slide, please. And here's what reimbursement is. So I'm not going to go through it, a ton, but just look at that. For an hour you put in with a patient under chronic care management, you're being reimbursed more than $168, about that, $168 a month is what you're going to be reimbursed. Now, if it's a complex patient and you do just an hour, it's $144, but you add an extra half hour to that, you're over $200 that you can get reimbursed. Folks, this is the time you are putting in anyway. We are not suggesting that you are going to do more work than you're already doing. Of course, you have to document this. Of course, it needs to be noted, and then you track your time, but you're already doing that. Do it. Give yourself credit for that. Next slide, please. Okay, so now we're going to move on to what are the types. We're going to just kind of transition into other areas of care coordination and the service lines. Types of wellness. There's emotional, psychological, and social. A lot of times when we think about people's wellness, we only think about that physical, but think about the other things that contribute to how a patient functions and how they're able to succeed in their life. Next slide, please. We're going to talk about behavioral health. Now, maybe you have heard integrated behavioral health, but I'm not talking about integrated behavioral health. I'm talking about behavioral health integration. They're two different things. They're billed differently, and they're usually done by different people. Behavioral health integration is part of the team-based approach that you're going to look at. You're going to help the patient if they're in a situation where mentally they need a little bit more help. They have some behavioral concerns, and you're going to be able to help them with that. Now, the integrated behavioral health is typically done by a social worker, and they can bill for that visit. They don't track time. It's a billable service. It's different. So just know there is a difference. And I'm telling you that because I was just on the phone call with somebody that works really, really high with FQHCs, and she was not aware that there is a difference. She said, we already do that. And I'm like, no, you do something different. So next slide, please. Okay, behavioral health integration, much like what we've already talked about with CCM. Team-based approach, you deal direct with the patient. It can be live or virtual. It's a single encounter, monthly service, or both. Maybe you talk to them once a month and meet their needs. Maybe you talk to them every week because they have that need. You track that time, and then you address their specific conditions. I also want you to know that you can do these services concurrently. CCM and BHI are concurrent services, and you layer them. Don't double dip and don't use the same diagnoses, but you can layer these for what you need to do for the patient. Next slide, please. So, as we've talked about, everyone within care coordination should function at their highest level of education. And in particular, we're talking about nurses. This is a quote from the American Nurses Association. In care coordination, it is up to RNs to step up and draw attention to the integral part they play in improving patient quality, satisfaction, and the effective and efficient use of the healthcare resources. That's what we can do as nurses. We are 100% qualified to be care coordinators and to be behavioral health coordinators. Next slide. Now, again, this is kind of small, but this slide says so much. Please take a second and just look at this slide. So, where is behavioral health care most provided? At the primary care provider's office. I want you to look at the line that goes over past 90%. The geriatric population that receives mental health at their PCP, over 90%. And I can tell you from my experience, that indeed is the case. Not that I'm geriatric and receive it there, but in my experience as a nurse, that is so much what I've seen. And then the other one I really like to look at, that's the next highest, that's just at 90%. How many times do patients have complaints and they're never able to find an organic base? These are patients that may need somebody to help them with behavioral health or mental health. That would be a good reason for a patient to be in your behavioral health program. So how is a patient eligible? Next slide, please. If the patient has any mental, behavioral health, or substance use disorders, that's not abuse, substance use, they qualify for it. The condition can be either new or pre-existing. The psychiatric condition is being treated by the billable provider. And what I want to throw in on this one is the provider had to have addressed it in one of their notes within the past 12 months. The ones that we see the most are anxiety, depression, and substance use. Those all fit right in there. And when we say that the billing provider will treat the member's chronic conditions, yes, they're also taking care of chronic conditions, but this is the behavioral health part of it. And you can take care of both of those in the primary care setting. And that's important to remember because patients need the help. Okay, so I want you to look at, next slide, please. I want you to look at this. So if a patient qualifies for care coordination, what is required for CCM? They have either Medicare or another insurance that's going to pay for it. They have 2 chronic conditions that have been identified by the primary provider. The patient consents and the provider initiates. So then in behavioral health and integration, same thing, Medicare or other insurance, 1 diagnosis is all they have to have. And then they have to consent. And then you need to start doing rating scales. Okay. You can't just look at the patient and say, I think their depression's about a 3 today. No, you have to do valid and reliable rating scales to determine that. And then you trend the patient. How are they doing? Are they getting better? Are they getting worse? And you trend that because that information is so important. Next slide, please. So the general BHI service component. So you have to do these assessments I already talked about. If they're on CCM and BHI, you have 2 care plans that address the different goals that you have set with the patient. The thing you will find with BHI is it takes a while to develop that trust. It's that continuous relationship. And they're not going to tell you right up front, you know, I've thought about killing myself for a few weeks. I just don't have the courage to do it. But if you have built that relationship with them, they may be very brutally honest with you. And that's what we're hoping for. Then you're going to help them facilitate and coordinate. Do they need a therapist? Do they need to see some sort of psychiatric mental health that can help with their medications? Does the provider need a little bit more help with the medications? Say it's somebody with schizophrenia and the provider's used all they know how to use and the patient's not seeing any benefit. Let's consult with psychiatry in some form. Next slide, please. This is where I mentioned, and I'll just say it real quick, that the provider had to have seen the patient within the 12 months and documented that they talked about the behavioral health. Sometimes this may be, you see the patient needs it, you see they're coming in to see the provider in a couple months, you put it down and talk to the provider about it and see if he'll talk about it. Next slide, please. So tracking time. So you can only track 20 minutes per calendar month for this. It's under general supervision. And it's not the time that the person at the front desk called them to schedule an appointment. It's not that administrative time, but it is. Say you had a very long conversation with them. Say you had a 10-minute conversation with them, but then you documented for another 10 minutes. You get that credit for what you are doing. Anything you do for or on behalf of the patient, you get to track that time. So it's important that the patient knows they've been admitted to that. So next slide, please. So now I'm going to talk a little bit about a program that's newer, and I know that time is getting tight, and I've been talking really fast with a lot of information. Like was shared with you by Michelle, you do have access to these handouts, and if you have questions, you can always reach out to me. But I want to talk about whole person care, ongoing care coordination, which is community health integration. This is a newer program that CMS began funding, and it is another program that you layer on top of CCM or BHI or other programs that you are doing. It doesn't have to be a standalone program, but it can be. So it meets the mental, the physical, and the social needs of the patient. Next slide, please. In order to start CHI, they must have a standardized evidence-based tool completed that identifies their social determinant of health risk or social drivers of health is also how that's been said. So it's a standardized test. It's usually completed at an E&M visit. It's billable. Doesn't pay very well, but it is a billable one. And you can do that every 6 months to bill for it every 6 months. You can do it more often than that if you need to. And it's usually done at an E&M visit, during an annual wellness visit, during a TCM, or any other visit that you're doing. And you can bill for it. I have on here that you must bill for it. Excuse me, I forgot to fix that. You don't have to bill for it as of 2026, but you can bill for it. But I do not know why you would not bill for it if you are, I don't know why you would even start community health integration with the patient if you have not done an SDOH risk assessment and know what their needs are. Next slide, please. I just wanted to show you real quick. This is the prepared tool. It's one of the screening tools that you will see. And for example, I know it can be found in Epic. I was just on help with a call the other day with a gal. She was in Epic, and this is the tool that they had in there. But there are other tools that you can use. There are 5 domains of SDOH, and these are the 5 that impact people. Sometimes we don't think about all of these, but education, access, and quality, healthcare access and quality, the neighborhood or built community, the social and community context, and the economic stability that patients face. All of these impact a patient's health. Next slide, please. So in order for this to be billable, you do give them a Z code. I'm not going to go through all of these, but there are 10 Z codes. Under each Z code, which is category, the Z category, I should say, there are multiple different diagnoses, and they're specific to that patient's need. Now, if the patient isn't currently, if they tell you, no, I have a place to live, I'm not homeless, but their home where they live, they've been moving from couch to couch with friends for the past 6 months, that's homeless. And this allows you to break it down that much. So here, there's 10 of them. I gave you 5 and then 5 more just so that you can see that. Next slide, please. We should be on the pre-visit planning. So after you've done the following, after you've done the SDOH screening, then you look at the SBAR situation with this patient. What did they present with? What were their needs? We did a screening and we recognize that these are their needs. Now, maybe they come in and they have 10 needs. Well, you're not going to try to tackle 10 needs in one visit. So break it down. Maybe you're going to tackle 3 of them at a time and know that the others are still there. So then you're going to get them into a community health integration program, and you're going to be able to bill for the GO136. Who, next slide, please. Who is going to run your community health program, community health integration program if you have it? Well, it needs to be done by a qualified personnel. That can be the nurse, that can be LPN. A community health worker is ideal. If you want some cool stories, do a Google, do a YouTube, and look up community health worker success. Some places in the upper Midwest have done so well with this because patients love and trust the community health workers that are part of their community. So some states require a certified, specialized training and certified CHW. Many states just require that they meet the qualifications, and that is that they can communicate, they understand, they know community resources, those type of things. The other thing to remember is you can't have 4 different providers billing for CHI per month. It can only be one provider. Next slide. Okay, this is pretty much like what we've already talked about with the others. Just keep in mind, a lot of these programs build on the other. So Medicare or other commercial insurance sometimes will pay for this. You need to have the initiating visit. You need to have completed the SDOH and identified that there are limitations to the patients receiving healthcare or maintaining their health because of their social drivers. Then you develop a treatment plan. Most of these the patient consents to, but most of this time is going to be non-face-to-face, okay? You do have to have, every month you have to at least see the patient. You know, you don't want to do fraud and keep billing and they passed away months ago and you said you were doing all this care on them. We don't want to do that. But it's a minimum of 60 minutes and a maximum of, I believe they changed it just last year. I believe you can do a total of 3 hours a month for the patient, and it's typically not in the office and it's not face-to-face. I want you to know that. So the majority occurs in the community. It is not the same as telehealth, okay? You're not billing it as telehealth. You're making phone calls. You're advocating for them. Maybe you're helping them apply for food assistance or housing assistance, or you're getting them into housing, helping them get medication assistance, those type of things may be what you do with CHI. We have one group we work with. One of the things they started doing for CHI was an exercise group, and patients loved it. They absolutely loved it because it met their health literacy and it met their lack of socialization needs. Those things were both so beautiful. Next slide, please. And then
Marcella,
the documentation. Yeah. Are we done?
Will you tell me which number slide you're on? I think I might have missed
49.
it. Oh, goodness. 49. I apologize, everyone. I'm well behind.
Well, I keep forgetting because I know I'm getting low. I'm getting low on time.
It's
I
okay.
Apologize.
You're doing great. Thank you.
Okay. CHA documentation. What must be documented? Okay. So the initiating visit and the provider, the patient consented. You're going to document their patient-centered assessment that has been completed. You're going to talk about the team-based care and obviously what unmet needs and what does that impact have on their health. If it is somebody who is unhoused and they are diabetic, think of all the ways that could affect them. Are they going to be able to refrigerate their insulin? Are they going to be checking, or do they have a clean area to even check their blood sugar? So next slide, please. These are the billing codes, and these are how you would bill for them. Like I said, the screening does not pay much. It's only $18, but guys, a penny's a penny. And then the first 60 minutes you can bill, it's $86, and then the 30-minute increments after that are $54 with the 30-minute increments. Now keep in mind, you cannot just bill the G0022 because you only got a half hour. You have to hit that hour first Then you can bill in the half-hour increments after that, the G0019 and the G0022. Okay, we're almost done, guys, I promise. So why do we do care coordination? Well, we're trying to get rid of those silos. We're trying to get rid of those, the fragmented care that the patients have received. So you do the team-based approach, but you have somebody who champions the program, somebody who's passionate about it, that wants this program to succeed. They're already doing the work. Let them get credit for what they're doing. It's well suited for a registered nurse. Use your highest level of education and do it as an integrated team. Together, everybody's aware. Hey, Edward Smith is on care coordination. He called in today and talked to the MA for 10 minutes about the wound on his leg. Whatever, document that, and obviously if it's a wound on a leg, it needs to be followed up. So those are things we're going to do. Why care coordination? We've talked about these. I just want to reiterate them. We're going to improve the patient health outcomes. We're going to streamline the healthcare across different providers, prevent that fragmented care. We want to contain health costs. We hear that every day if you turn the news on. You want to decrease medical errors. None of us want, I'm going to share a quick story here. I had a dialysis patient we took care of who was getting a small lump on his head. We referred him back. He'd had cancer in the past. We referred him back to oncology. They ordered a CT scan. This was before EMRs were to the point they are. The CT scan was done. The printed copy was put in the chart, and the oncologist never looked at it. When they discovered it, it was too big at that point to do anything, and it was a renal tumor that was metastasized on his brain, and he ended up dying from a stroke caused by that tumor. That is a medical error that could have been prevented. So patient needs are communicated, patient needs are better met. So I am now, last slide that says questions. I know I went fast. I apologize for that. You do have a copy of the slide with my notes on it. I don't think I made it a PDF before I sent it, and I'm fine with that. If you have any questions, I think we have a few minutes, Michelle. Thank you for your patience with my technology. I still don't know why I lost it.
That's all right. Let's see. Let's go to the questions pane. Miss Julie, you're correct. The slides were not corresponding, and that's my mistake. Pardon me. And Miss Catherine, I will make sure that this video is uploaded this afternoon, and I will share the link out to the YouTube link as soon as it's prepared. Okay, are there any other questions? I'm so glad you guys hung in there. Thank you for that. Sorry about all the technology mishaps.
Truly, truly, this is what you get when you think technology is going to be right there.
Thank you, Miss Cash. We've got some thumbs up. Appreciate that.
Thank you. And just so you all know, I'm passionate about this. My email address, if you go to the very last slide, my email address is there, and I believe it was on the first slide as well. You can reach out to me with questions. If you already have a program and you just want to verify some things, let me know. If you're new to it, we do offer education, and I'm willing to support and encourage because I'm passionate about this, and I think every Medicare patient needs to have this kind of support.
Okay, Miss Tiffany Simon from Children's Nebraska has a question. She works in a pediatric setting. Can these codes be used with Medicaid?
You would have to check with your specific state. Sometimes they do cover CCM and BHI. I do not believe any of them have picked up CHI yet, but potentially. Right. Like in Wyoming, they cover Medicare or Medicaid, excuse me, covers, this is crazy, they cover CCM one, they'll do 20 minutes of it, and then they cover the extension of BHI, but not BHI. So, and I didn't go into that, but I'm just telling you, it's kind of an odd thing that the way Wyoming did it. So I don't know what your specific state would do with it.
Marcella, will you share your email, please, for the group?
Yes, it is Marcella.Wright. I don't know if I can share it on my phone, guys.
WRIGHT.
Yep. At HealthTech health-us.
Okay, so I'll include that in the email blast.
Perfect.
Email slides. All right, everyone. Thank you so much again for hanging in there, and I will get this loaded this afternoon. And everyone, thank you, Laura. Appreciate that. Everyone, have a great day.
Thank you, Michelle, for carrying the load.
Hey, you bet. And we hope to see you all at the summit in October. We'll be in Omaha, or just outside of Omaha, Nebraska. I know HealthTech will have a booth, so
That's
pleased.
awesome. I know Sherry's going to be there, so that's awesome.
Yeah, she's wonderful.
Yeah. Thank you so much.
Thank you, Marcella. Bye, everyone.
Bye.